Welcome to the e-learning module on pathology of nutritional anemia. This session is on definition and classification of anemia. So what is anemia? Anemia is reduction of total circulating red cell mass below normal limits affecting tissue oxygenation. The other way to define anemia is it is reduced hemoglobin concentration in blood below the lower limit of normal range for age and sex of the individual. So the normal range for various age and sex differs. That is why the definition is like this. So in adults, hemoglobin of less than 13 in males and less than 11.5 in females can be considered as anemia based on the hemoglobin. So what are the symptoms whenever the patient has anemia? So the symptoms can be fatigue, dizziness, and brittle nails, reduced exercise tolerance, dyspnea, headache, and in females, menstrual irregularities, loss of appetite, and also they will present with swelling of the limbs, that is peripheral edema. And when you examine, there will be pallor, there will be cold, calm skin, brittle nails can be examined, and also there is edema. So how to do classify? So how to classify the anemia? So anemia can be classified based on the morphology. So what is the meaning of morphology? How does these RBCs appear either in the peripheral smear or based on the RBC indices, or anemia based on the etiology or pathophysiology. So this tells about what is the cause of anemia. So anemia can be classified based on two. So morphology or etiopathophysiciology. So based on the morphology, so for classification of anemia for based on the morphology, we need either peripheral smear examination or red cell indices, which include MCV, which assesses the size of the RBC, or the hemoglobin concentration, that is MCH and MCHC. So how do you assess the size or chromia of the RBCs? It is by either peripheral smear examination. So in the peripheral smear, we can assess the RBC size by comparing it with a size of small lymphocyte nucleus, as I told in the previous session. How do you assess the chromia? Normally, the RBC should be having only central one-third pallor. So more than one-third pallor can be considered as hypochromia. So based on the RBC indices, the normal RBC indices, the size which is assessed by MCV, normally it should be 80 to 100 femtoliter, and MCH should be 28 to 32, and MCHC should be 32 to 32 to 36 picograms per deciliter. So based on the morphology in the peripheral smear, they can be classified as macrocytic, microcytic if it is smaller, or normocytic. And based on the chromia, we can classify it as either hypochromic or normochromic. And based on the red cell indices, if it is between 80 to 100, it is normocytic. If it is less than 80 femtoliters, it is microcytic. If it is more than 100 femtoliters, it is macrocytic. And if MCHC or MCH, it is below or within normal limit, we can classify it as either hypochromic. If MCH and MCHC is less than the required amount, it can be hypochromic. If it is within normal range, it is normochromic anemia. So we need to know what are the causes for each type of morphologic type of anemia. So if it is microcytic hypochromic anemia, the four common causes are SITA, SITA. The short form is SITA, that is sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. So, but the most common cause among this is iron deficiency anemia. So, other than that, even the poisoning can lead to microcytic hypochromic anemia. So the causes for macrocytic anemia, so based on the bone marrow findings or serum investigation, we have megaloblastic or non-megaloblastic anemia. So causes for megaloblastic anemia is deficiency of vitamin B12 or folic acid, which are vitamins required for synthesis of the RBC in the bone marrow. Non-megaloblastic means that will be telling in the next section. So the causes for non-megaloblastic anemia are either hypothyroidism, alcoholism, chronic liver disease, or myelodysplastic syndrome. Causes of normocytic, normochromic, or hypochromic anemia are either chronic blood loss, hemolysis, or there is a reduced production that will be seen as reduced reticulocyte count. So under this, either aplastic anemia, anemia of chronic disease, or chronic renal failure. So these are the causes based on morphological classification. So next important type of classification is pathophysiology or etiological classification based on the cause of anemia. So in this, we have three broad categories. So it can be because of blood loss, or it can be because of reduced red cell production, or the third cause is there is enough production, there is no blood loss, but there is increased red cell destruction. Because of some cause, there is increased red cell destruction. So this type of anemia is called as hemolytic anemia. So the first group is blood loss. So blood loss can be acute or chronic. So what could be the cause for acute blood loss? It can be major trauma, either road traffic accident or internal hemorrhage, which is acute. Chronic blood loss, there are plenty of causes. It can be bleeding through various cavities, either nasal cavity or coughing up of blood, that is hemoptysis, hematemesis, vomiting of the blood, or there is some internal chronic blood loss, especially in GI diseases like peptic ulcer in the gastric, or duodenum, or chronic hematological malignancies can lead to chronic blood loss. So next, second group is anemia due to reduced red cell production or impaired production. So the production of the RBC. So the main the part of the RBCs is mainly hemoglobin. But before hemoglobin production, there are various, as I taught in previous session, there are various steps in hematopoiesis. There is erythroblast, early erythroblast, intermediate, late erythroblast. So in that step, we have RBC precursor, which is having nucleus. So in stepwise manner, to undergo maturity in stepwise manner, we have to have cytoplasmic maturation and nuclear maturation. So the impaired red cell production can be because of impairment in the cytoplasmic maturation, that is the first group, or impaired nuclear maturation, or it can be disorder affecting the stem cells. So as I told, the beginning step in hematopoiesis is stem cell. So there can be some disorder affecting these stem cell itself, or some other disorder affecting the bone marrow, which is the site of synthesis of RBC. So what are the causes for cytoplasmic maturation defect? So the cytoplasm has hemoglobin. So hemoglobin has heme and globin. So cytoplasmic maturation defect can be because of defect in the heme production or defect in the globin production. So defect in the heme production is mainly because of iron deficiency, or defect in the globin production is because of thalassemia. So nuclear maturation requires vitamins, two vitamins, that is vitamin B12 and folic acid. So deficiency of these two can lead to nuclear maturation defect, leading to impaired red cell production. Stem cell disorder, either it can be the stem cell in the beginning, that is called as aplastic anemia, or stem cell which is particular for red cell synthesis. So that is called as red cell aplasia. So other disorders are mainly affecting the bone marrow. Either it can be infection in the bone marrow, like a chronic TB, or any infection or parasitic infection affecting the bone marrow, or it can be metastasis. So what is metastasis? Is a spread of the tumor. So metastasis to the bone marrow, or leukemia, which is hematological malignancy itself. So leukemia can completely replace the RBCs in the bone marrow, or anemia of chronic disease. So these are the other causes of impaired production. Third group of anemia based on the etiology are increased destruction of the RBCs, that is hemolytic anemia. So there is some classification of hemolytic anemia. So based on the whether it is hereditary or acquired. So in hereditary, we have disorder which is affecting the red cell membrane, or disorder affecting hemoglobin production, or disorder affecting enzyme which are there in the RBCs. So membrane defect, there are two diseases, hereditary spherocytosis and elliptocytosis. So disorder of the hemoglobin, it can be qualitative or quantitative. So what is qualitative? There is defect in the hemoglobin effect itself. There is defect in the structure of hemoglobin. Whereas quantitative means the amount of hemoglobin produced is reduced. So that is quantitative. Then we have enzyme defect. So in that we have two disorders, anemia due to G6PD deficiency or pyruvate kinase deficiency. So all these comes under hereditary hemolytic anemia. So the next group is acquired anemia. So in acquired, we have again subtypes, immune or non-immune. Immune is either autoimmune anemia, that is autoimmune hemolytic anemia, AIHA, or alloimmune hemolytic anemia, or it can be because of drug induced, various drugs which are causing immune hemolytic anemia. In non-hemolytic anemia, it can be mechanical damage to the RBCs, or it can be various factors which are causing direct toxic effect on the RBCs or other causes. So mechanical injury to the RBCs can be because of microangiopathic hemolytic anemia, where there will be a thrombosis in a small blood vessel. So when RBCs pass through these blood vessel, there will be destruction of the RBCs. That is leading to hemolysis, or there is defective heart valve. So direct toxic effect on the RBCs can be because of snake bite or some infection affecting the RBCs like babesiosis or malaria, or some chemical like lead poisoning or sepsis. Other disorders are acquired membrane defect, which is paroxysmal nocturnal hemoglobinuria, that is PNH, which is an acquired cause of hemolytic anemia, or it can be hypersplenism. So coming to nutritional anemia, what is nutritional anemia? So these are anemia because of deficiency in various factors which are required for, which are very essential for production of new RBCs. So we have three type of nutrients which are required for RBC synthesis: metals, vitamins, and amino acid or protein. Okay, so metal, among metals, iron, cobalt, and manganese are required for red cell production. So among which iron is the iron which is most important. So iron forms part of the heme molecule in the hemoglobin. So this will be leading to type of anemia which is called as microcytic hypochromic anemia. So cobalt and manganese deficiency also can lead to impaired red cell production. Second is vitamins. So the most important vitamins are vitamin B12 and folate, which are required for synthesis of the nucleic acid, or for maturation of the nucleus. So the deficiency of these two vitamins can lead to megaloblastic anemia, which is a type of macrocytic anemia. Other than that, deficiency of vitamin C can also lead to anemia. So vitamin C is required for absorption of the iron, or they can also lead to hemolysis. So vitamin C deficiency can lead to indirectly iron deficiency, or it can lead to hemolysis. Vitamin B6, that is pyridoxine, vitamin E or riboflavin are the other essential vitamins which are required for synthesis of the RBC. Third group is amino acid. As we know, a globin component of hemoglobin is nothing but protein. So proteins are nothing but made up of amino acid. So severe amino acid deficiency because of protein deprivation can lead to decreased red cell production. So in nutritional anemia, The most common cause of nutritional anemia are lack of iron, vitamin B12, and folic acid. So among these three, the most commonest form of anemia, nutritional anemia, is iron deficiency anemia. So to summarize, how to define anemia? Anemia is reduction of total circulating red cell mass below the normal limits affecting tissue oxygenation. In other way, we can tell based on the reduced hemoglobin concentration. So how to do the classification of anemia? Anemia can be classified based on morphology or etiology or pathophysiology. So what is nutritional anemia? The most common causes for nutritional anemia are iron, vitamin B12, and folic acid deficiency. So other causes of nutritional anemia includes copper, deficiency of vitamin E, protein, riboflavin, or pyridoxine deficiency. These are the references. Thank you.